As we get into our secondary assessment, we'll really get into our inspection, our palpation, and our auscultation. So the systemically assessing our patient, I'm just going to start and work my way down. I'm going to do the head. So I'm palpating for that decap BTLS on the head for the bones. I'm looking at the eyes, ears, nose, and mouth. You know, what do I smell? Do I see any fluids? Ears. Do I see any bruising behind the ears? Then at the neck, do I palpate? And this is where we have to practice. We have to know what's normal, so when we feel abnormal, it's like, whoa, what's wrong? Or have you know, sometimes like with the spine, it's, you know, you may ask, hey, have you ever had a herniated disc or a displaced disc or something like that? So when you find those things, then I come around to the front of the neck. You know, I'm looking for JVD, tracheal deviation. So I want to make sure everything's midline and that my jugular veins are pretty flat. We don't want to see them really distended. Do I see any cuts, lacerations, anything like that as well? Then I come around to the neck. You know, I'm looking at the neck, palpating, feeling. The clavicles, I come down the sternum. Is all that in order? As well as lung sounds. I'm going to listen high, I'm going to listen low, to the sides, and then to the back if I can get to it. So lots of different places to listen to my lung sounds. Can they take a deep breath? Is it equal on both sides? Equal rise and fall of the chest. Then the abdomen, the 4 quadrants of the abdomen. And do I see any bruising, tenderness? Do they have any complaint? Pelvis, you know, when you squeeze just a little bit and push just a little down, do they complain? Or everything looks good? Genitalia as well. Don't miss this. Patients can bleed out and die in the genitalia and you miss it because you don't check it. Anytime you suspect a pelvic fracture, just check. And usually it's nothing more than, you know, looking at underwear to see if there's blood. And a lot of times if it's that significant, it'll be there. And it's like, oh no. Then you get to the arms and legs, and I want to check for pulse, motor, and sensory. Can they feel? Both on my upper and lower extremities. Now with shock, a lot of times the lower extremities are not going to have pulses that you can find because everything's shunning up. But you can say you at least tried. Or if you get there early enough, you may have pulses when you first begin and you lose pulses. Well, it may not be because of your fractures or whatever, it's because of the shock of everything else that's going on. So, note what you had before, note what changed after. And then when you're able to get the patient up on their side, rolled over and check the posterior. So you're checking the back of the head, the back of the neck. Check their back, their scapula, the lower part of the back around the kidneys, going back to the buttocks and then the back side of their legs. So work your way down. As you're listening to breath sounds, you know, some of those adventitious breath sounds, that wheezing, that stridor, rails, crackles, any of that jumps out at you that should we be fixing something or what caused it. So respiratory rate, I'm looking for my rate, rhythm. Is it regular, irregular? And what's the quality or the characteristic of their breathing? What's their depth of breathing? If they've got a chest injury, they're going to be very shallow because it hurts to breathe. So we want to note that. So what kind of good tidal volume are they getting, or are they not getting good tidal volume? Rhonchi was the other one I didn't mention. So that congested breath sounds. Maybe mucus in the lungs. Then as I get into my heart rate, so is it tachycardic? Are they bradycardic? So fast heart rate, slow heart rate. They're not in that normal that we like to see, 60 to 100. Then what's that blood pressure? You know, if I know that they've lost a lot of fluid, I expect that blood pressure to be low. Then what's their systolic versus their diastolic? If they're getting close together, that tells me they could have a problem around their heart. Not something I can do, but something I can get them to a surgeon for and give them a heads up. So, we'll check blood pressures. We're going to be watching for hyper and hypotension. And then we're going to do our neurological assessment. So we've already talked about, you know, asking questions, person, place, time, and event. That also will help you with your Glasgow Coma Scale. So I'm looking at my eyes opening, my best verbal, and my best motor responses. So with the eyes opening, if they're spontaneous, they get a 4. In response to speech, they get a 3. Response to pain, they get a 2. And none, they get a 1. So dead patients still get a 3 on their Glasgow Coma Scale or their GCS. Their best verbal, if they're oriented, they're answering questions, having a conversation, they get a 5. If they're confused, they get a 4. If they're inappropriate, they get a 3. If they're incomprehensible, so I can't understand what they're saying, they get a 2. And then if they have none, they get a 1. Then their best motor, so they obey commands, they're a 6. They can localize pain, they're a 5. They withdraw pain, they get a 4. They abdominal flexion, 3. Extension, or flexion, 3. Extension, 2. And then none, 1. Pupils equal and round, regular in size, react to light. So pearl. So when I'm taking my light, shining it in their eyes, do they respond? The only time they shouldn't is if they just come from the doctor's office and they had their eyes dilated and they're going to be about that big and they don't respond. And that light's probably going to hurt their eyes too. Subcutaneous emphysema, so when you palpate the neck or around the neck for signs of trauma such as deformities, bumps, swelling, bruising, and bleeding, as well as crackling sounds produced by air bubbles under the skin, also known as your subcutaneous emphysema. So it sounds like Rice Krispies. Your Rice Krispies underneath around the neck, upper part of the chest is your sub-Q air. Paradoxical motion is when the chest, one side moves, the other side does not. So that's never good. Some of the other things we may use is our pulse oximetry as an assessment tool to establish effective oxygenation. We want to see that at least above 94% if we can. The other thing is capnography, and capnography helps us with metabolism. It refers to the chemical reactions that occur in the body and cells to maintain life. So to get an idea of the patient's metabolism, you can measure their carbon dioxide levels in the air that the patient exhales. So we like to see that between 35 and 45. It's non-invasive. We can put it on a nasal cannula, or if we put an iGel or king in, then you can put it on the end of your tube and you'll see if your CPR is working well. We have blood glucose that we can do. We also have non-invasive blood pressure monitoring measurement that we can use. And then ultimately we want to reassess. Anytime we do anything, we want to reassess it. Give it, that 5 minutes and then reassess and make sure it's good to go. Recheck our interventions, make sure whatever we've done is still working. Reassess our vital signs. We want to show a trend in our vital signs. We hope it either stays the same, it doesn't trend down. If it was already a little low, I would rather see it trend up, but at least staying about the same. And just go back. If you found something, go back and relook. You want to make sure that you reassess the patient just because things change. You didn't see that bruise when you first started. Wasn't there when you first started. So now as the patient is being transported, it's progressing and you're seeing that progression. So you're finding more things. So do a good assessment. We will practice this a lot, but that gives your down and dirty. Thanks.